Good morning. Today we will talk about disorders of hemostasis in children. The objectives of this lecture: first, to describe the bleeding manifestation with various clinical presentation, lab tests, and diagnosis. Then we list the causes of thrombocytopenia and outline the steps for diagnosis of immune thrombocytopenia. Finally, we'll describe the clinical manifestation and diagnosis of hemophilia, von Willebrand disease, and Henoch-Schönlein purpura. How we define normal hemostasis? It is an active process with the formation of blood clots in the area where there is a blood vessel injury. However, this process will simultaneously limit the clot size, which is only limited to the area of injury. As you know, as a result of injury to blood vessel endothelia, the events take place are as follows. First, we will have vasoconstriction of injured vessel, what we call it the vascular phase. And after vasoconstriction, the platelet will adhere to that site with their aggregation to lead to formation of a platelet plug. This is called a primary hemostatic mechanism or a platelet phase. Also, at the same time, due to secondary hemostatic mechanism and activation of a plasma phase, we will have fibrin thrombus formation. So hemostatic failure is present when there is inappropriate and excessive bleeding, which is either spontaneous or a response to injury. 80% of correct diagnosis of bleeding disorders can be made by proper history taking and physical examination. What are the clinical manifestations of bleeding? We have mucosal bleeding, mucocutaneous bleeding like easy bruises, epistaxis, petechiae, menorrhagia, or oozing from surgical wound. This is usually consistent with a defect in a primary hemostasis, like defect in platelets, also von Willebrand factor or vessel wall. As you know, von Willebrand factor has two functions. It is a carrier for factor VIII, as well as it enhances the platelet adhesion to the injured endothelia. So it has shared manifestation between bleeding and coagulation disorders. Other manifestation is deep tissue bleeding in forms of hematomas, joint and muscle hemorrhage, with delayed surgical bleeding. These are suggestive of coagulation factor abnormalities, for example, hemophilia. In this picture, you can see primary hemostatic defect. Here, the patient has a mucocutaneous bleeding, while on the right side, as you can see in the picture, there is either joint hemorrhage causing hemoerythrosis or muscle hematoma, which is indicative of secondary hemostatic defect. In this slide, you can see petechiae. These are fine pinpoint red dots which do not blanch with the pressure, and they are not palpable. Presence of petechiae is typical of a platelet disorder. In this table, you can see the different clinical manifestation of hemostasis. We have two major groups, the platelet defect and the clotting factor deficiency. Regarding the site of bleeding, in a platelet defect, usually skin, mucous membrane like gingiva, nares, GI, and genitourinary tract. While in a clotting factor, it is deep in soft tissue like joint and muscle. Bleeding after minor cut is common in a platelet defect, unusual in a clotting defect. Petechiae are present in a platelet defect, absent in a clotting defect. Ecchymosis is usually small and superficial, with a platelet defect large and palpable in form of hematomas like in a clotting defect. Hemolythrosis and muscle hematoma, as we said, are rare in a platelet defect but common in clotting defect. Bleeding after surgery, it is usually mild and immediate with a platelet defect delayed and severe in a clotting defect. How we evaluate a patient with disorders of hemostasis. First, we should determine in the history whether the bleeding is local or systemic. Second, whether it is a single versus multiple sites of bleeding. Also, we ask about the duration of hemorrhage, hereditary versus acquired disorder by asking about the onset. For example, in hereditary disorder, the onset is usually early in infancy, while delayed onset goes with acquired disorder or mild hereditary disorder. Family history is very important. Underlying disease which might cause disorder in hemostasis also, we should look for it. We should know whether this is a primary or secondary hemostatic disorder, whether there is a previous personal or family history of similar problem. Also, severity is very important, whether bleeding is spontaneous or occur after trauma, and whether the symptoms correlate with the degree or severity of injury or trauma. Sometimes mild trauma causes severe bleeding. This is the degree of a trauma is not correlated with the amount of bleeding, which might indicate presence of underlying hemostatic disorder. Whether the child had any surgery which affected mucosal surfaces like tonsillectomy or major dental extraction, the absence of bleeding in this operation usually rules out a hereditary bleeding disorder. Ask about history of circumcision in males and careful history about menstruation in adolescent female and history of a drug intake, for example, anticoagulant, non-steroidal, anti-inflammatory drugs, and cytotoxic. What are the lab tests that can be done in a patient with hemostatic disorder? The first line, what we call it, the screening test, and second line are specific tests. These are essential to screen, diagnose, and monitor the patients. We talk about first-line screening tests. First, start with complete blood count, including peripheral blood smear. Then, bleeding time usually stops within 4 to 8 minutes, and the test should be done only when platelet count is normal. To exclude a functional defect, please keep this in mind. Don't do bleeding time when the platelet count is low. Platelet function analyzer to evaluate the platelet function and von Willebrand function interaction. Prothrombin time is a measure of extrinsic pathway, which is related to factor 7 deficiency and other common pathway 5 and 10 prothrombin fibrinogen clotting factors. While partial thromboplastin time measure the contact system, which is the prekallikrein or factor 12, as well as intrinsic mechanism, including factor 8, 9, and 11. Also common pathway clotting factors mentioned above. Thrombin time usually measure fibrinogen deficiency. The second line specific tests are by assessing the clotting factors. In this picture, you can see the test for bleeding time. We have two methods, the Duke test when the puncturing the ear lobule and taking drop of blood on the filter paper every half minute until it stops. While in IV method, we inflate the cuff of a sphygmomanometer to a level between systolic and diastolic pressure, and then puncture the inner surface of the arm and measure the time needed for bleeding to stop. This measures the bleeding time. In this algorithm, you can see the lab evaluation of a bleeding disorder. If there is a clinical history of a bleeding, then we should do screening tests mentioned, complete blood count, blood smear, PT, PTT, bleeding time, and the platelet function analyzer. If the PT and PTT are abnormal, as we mentioned, PTT only prolonged. This indicates intrinsic pathway factor 8, 9, and 11. If only PT prolonged, then it is factor 7. If PT and PTT both are prolonged, this is a common pathway factor 5, 10, prothrombin, and fibrinogen. Other causes for abnormal PT-PTT is the presence of lupus anticoagulant or the presence of inhibitors. In this case, we should do lupus anticoagulant screen and mixing the study. If there is no abnormalities in the screening test on the right side, then this indicates either factor 13 deficiency, which needs a specific test for its diagnosis. And also we should consider rare fibrinolytic disorder and evaluate for connective tissue disorder or child abuse. But for a patient who has abnormal complete count and the blood film, bleeding time, or a platelet function analyzer, then he has either von Willebrand disease. In this case, we will assess the von Willebrand factor antigen, the ristocytin coactivity, and von Willebrand factor multiple and ristocytin induce platelet activation. But if there is a platelet disorder, whether congenital or acquired, then we should study the platelet count morphology, aggregation, also do electron microscopy for some defect of platelets, review if there is any medication taken by the patient, or evaluate for other systemic disorder like liver and renal diseases. First, we will start with the platelet abnormality. We have the quantitative abnormality and the qualitative. The quantitative, either due to decreased bone marrow production when there is malignant marrow infiltration, like leukemia, drugs causing thrombocytopenia, or severe megaloblastic anemia, or hypoplastic or aplastic anemia. Or it is due to decreased platelet survival when there is peripheral consumption, either due to immune mechanism in a primary immune thrombocytopenia or secondary to lymphoma SLE, or drugs like thiazide and sulfonamide. The other cause for decreased platelet survival is excessive consumption, like disseminated intravascular coagulation and the presence of hypersyphilism. The qualitative disorder, either inherited like Bernard-Solier syndrome, which is associated with defect in a platelet adhesion, thrombocythemia, or a Glanzmann disease, which is due to defect in a platelet aggregation. For both adhesion and aggregation, there are specific receptors present in the platelet, and defect of these receptors lead to development of these inherited disorders. The acquired platelet abnormality are more common, like myeloproliferative diseases in patients with a chronic renal or chronic liver disease, taking the drugs like aspirin and non-steroidal anti-inflammatory drugs. We start with immune thrombocytopenia. It is the most common cause of a thrombocytopenia in children. It is characterized by isolated low platelet count. Normally, the platelet count is 100 to 150,000 per cubic milliliter. This is the lowest normal. The upper is 450,000 per cubic milliliter. As we said, it is the most common cause of acute onset of a thrombocytopenia in otherwise well child. Usually, the patient gives 1 to 4 weeks history of exposure to common viral infection or flu-like illness or upper respiratory infection. As a result of that, he will develop autoantibody directed against the platelet surface. And this anti-platelet antibody will bind to platelet surface, enhancing their destruction in the liver and spleen. The clinical manifestation, as we said, the classic representation in a previously healthy child with sudden onset of generalized fatigue and purpura. Often there is a bleeding from gums and the mucous membrane, especially when there is a profound thrombocytopenia, that is to say platelet count less than 10,000. Physical examination normal other than presence of fatigue and purpura. There is absent hepatosplenomegaly or remarkable lymphadenopathy, which might suggest other diagnoses like leukemia. The manifestation varies in severities, either the patient asymptomatic or he has mild bruising, fatigue, occasional minor epistaxis with very little interference with daily living, or it is a moderate presentation symptoms like more severe skin and mucosal lesion, more troublesome epistaxis or menorrhagia in adolescent girl. Sometimes the bleeding is severe with menorrhagia, epistaxis, melena, requiring a transfusion or hospitalization with symptoms that interfere seriously with the quality of life. In this picture, you can see on the left side fatigue and ecchymosis, while on the right side, the subconjunctival hemorrhage. This is a serious sign, which is a herald sign for CNS bleeding. In this table, you can see the relation between a platelet count and the bleeding. When the platelet more than 100,000, no sign and symptoms. Between 50 to 100,000, there is minimal bleeding, usually after major trauma or surgery. But when it is between 20 to 50, then we have mild cutaneous bleeding. Between 5 and 20, it is moderate, usually cutaneous and mucosal. But when it is less than 5, there is a risk of severe mucosal and might be CNS hemorrhage. The lab finding, as we said, the platelet count usually severe, less than 20,000 per cubic milliliter. The hemoglobin white cell count differential should be normal. Bone marrow examination is normal or show an increased megakaryocyte to compensate for peripheral destruction of a platelet. As we know, the bone marrow examination is optional, but there are specific indications for doing bone marrow, including abnormality in white blood cell or differential, whether there is unexplained anemia or findings suggestive of bone marrow disease in history and physical examination like hepatosplenomegaly or lymphadenopathy. What are the general considerations in management? Our goal of treatment is to achieve adequate hemostasis by raising the platelet to more than 20,000 per cubic milliliter and prevent the rare intracranial hemorrhage rather than achieving normal platelet count. This is very important to be kept in mind. The majority of the patients with no bleeding or mild moderate bleeding, they can be treated by observation alone, regardless of their platelet count. But if the patient is symptomatic or his bleeding interfere with the quality of life, or the parents are very anxious, then we might start first-line treatment, which include, in addition to observation, corticosteroid, like prednisolone or dexamethasone or methylprednisolone, intravenous immunoglobulin or anti-D immunoglobulin. This is on the right lower side of the slide. You can see this sentence is very important and should be kept in mind that a platelet transfusion should be reserved only for life-threatening bleeding and CNS hemorrhage, because their half-life is very short in patients with ITP, as well as they stimulate the production of more antibody to destroy them. So avoid giving a platelet transfusion in any patient with immune thrombocytopenia. Prognosis of ITP, in 70 to 80% of children who present with ITP, there will be spontaneous resolution within 3 to 6 months. Less than 1% they have intracranial hemorrhage. Fortunately, it is very rare. While 20% of children are going to have a chronic ITP, which is persistence of symptoms more than 1 year. Now we talk about coagulation factor deficiency, either congenital, characterized by single factor deficiency. They are clinically apparent at birth, but mild deficiencies, as we said, might not become apparent until later in life, in adolescence or adult life. The most common type of coagulation disorder, hereditary disorder, are hemophilia A due to factor A deficiency, hemophilia B due to factor 9 deficiency, or a Christmas disease, von Willebrand disease, and factor 11 deficiency. The second coagulation factor deficiency is the acquired type, which is more common and usually associated with multiple factor deficiency, which is either secondary to underlying disease or a drug treatment. It is due to decreased production, for example, liver disease, vitamin K deficiency, especially in neonate and patient with malabsorption, or due to increased consumption in disseminated intravascular coagulation, or the presence of circulating inhibitors, antibodies towards factor VIII in SLE. Drugs like heparin and warfarin, dilution causing coagulation factor deficiency when there is massive bleeding, blood transfusion or rapid transfusion, for example, in patient with a road traffic accident. We talk about factor 8 and 9 deficiency, hemophilia A and B. In fact, they have the same clinical manifestation. The deficiency of these two factors are the most common severe inherited bleeding disorder. The clinical manifestation, as we know, neither factor 8 nor factor 9 crosses the placenta, so bleeding symptoms may be present since birth. 2% of neonates with hemophilia, they might develop intracranial hemorrhage, while 30% of male infants with hemophilia bleed with circumcision. Obvious symptoms of hemophilia and with easy bruises and intramuscular hematoma or hemarthrosis, bleeding in the joint, usually begin when the child starts to cruise or creeping. In this pedigree picture, you can see both parents, the father, either the mother is normal and the father here have hemophilia. So the daughters all carrier because they take the disease X from their father, while the sons are unaffected. Another picture when carrier mother married a non-hemophilic father, then this mother will have 50% chance of having carrier daughters, and half of her son will have hemophilia. If a carrier mother marry a father with hemophilia, then we have either 50% of the girl will be carrier, other 50% will be affected, and also 50% of the sons will have hemophilia. If mother and father both have hemophilia, then all the children will have hemophilia, both males and females. If the mother have hemophilia but the father non-hemophilic, then, as we said, all girls are carrier, while all the boys are affected. Clinical manifestation of hemophilia, the hallmark is development of hemarthrosis or bleeding in the joint. This may be induced by minor trauma or may be spontaneous. Life-threatening bleeding in patients with hemophilia is caused by bleeding into vital structures like CNS, upper airway, GIT, or iliopsoas muscle hemorrhage. The lab finding showed the prolonged PTT in both deficiencies. Platelet count, bleeding time, prothrombin time, and the thrombin time are normal. A specific assay for factor 8 and 9 will confirm the diagnosis of hemophilia A and B. Treatment by early appropriate therapy, which is the hallmark of excellent hemophilia care. Factor 8 or 9 concentrate can be given when there is mild to moderate bleeding. Here the level must be raised to hemostatic level about 35 to 50% range. But for life-threatening or major hemorrhage, the dose should aim to achieve 100% activity. Other form of treatment, desmopressin in mild hemophilia A, but not effective in hemophilia B. Why it is effective in hemophilia A? We know that factor 8 is produced by endothelia of the vessel. So when there is mild deficiency, desmopressin will enhance release of factor 8 from the vascular endothelia, while factor 9, is usually produced by the liver, and desmopressin here is not effective in hemophilia B. Prophylaxis treatment nowadays used especially in developed countries or other country by using recombinant factor 8 or 9 product to aiming to be the standard of care for most children with severe hemophilia to prevent spontaneous bleeding, early joint deformity, and having a good quality of life. Supportive care, we always advise the parent that their child should avoid trauma, avoid violent contact sport, with early psychosocial intervention to support the family, achieving balance between overprotection and permissiveness. Avoid the drugs like aspirin, non-steroidal anti-inflammatory drugs which affect platelet function. Giving the child vaccination against hepatitis B, even with the use of recombinant products. Patients who are exposed to plasma-derived products should be screened periodically for hepatitis B, C, HIV, and liver function tests. Chronic complications of hemophilia are chronic erythropathy leading to destruction of the joint and formation of ankylosed stiff joint, development of inhibitor to factor 8 or 9, risk of a transfusion-transmitted infection like hepatitis B, C, and HIV. Education remains crucial in hemophilia care. This is a picture for a patient with destroyed ankylosed joint. As you can see here, he has atrophy of the muscle of the legs due to misuse atrophy. Now we talk about von Willebrand disease. It is the most frequent inherited bleeding disorder which affects 1 to 2% of general population. It is less severe than hemophilia, and it results from decrease or absence of von Willebrand factor required for a platelet adhesion. And that's why it affects primary hemostasis due to defect in a platelet adhesion. The clinical manifestation, generally, the patient has mild bleeding, often unrecognized, or when he has surgery or injury. They might present with epistaxis, menorrhagia in females, easy bruises, dental, and post-operative bleeding. It can be severe in certain type. It requires accurate diagnosis by using a platelet function analyzer, and also it requires a specific treatment. The types of von Willebrand disease, we have type 1, which is the most frequent. It is associated with a quantitative defect in von Willebrand factor. It is decreased but not absent. while type 3 is severe and rare, associated with absent von Willebrand factor. This is similar to hemophilia A. While type 2, then the factor of von Willebrand disease is normal, but it has abnormal function due to qualitative defect. The lab finding there is long and bleeding time due to defect in platelet adhesion and long partial thromboplastin time due to defect in factor 8. As we know, von Willebrand factor has two functions. It is a carrier for factor 8 and help adhesion of platelets. Normal result on screening test doesn't exclude the diagnosis of von Willebrand disease. This should be kept in mind. If history is suggestive of mucocutaneous bleeding disorder, then von Willebrand testing should be undertaken, even if screening tests are normal. Treatment is directed toward increasing the plasma level of von Willebrand factor and factor 8. Current replacement therapy by using plasma-derived von Willebrand factor containing concentrate that also contain factor 8. These are usually the cryoprecipitate, which contain both fibrinogen, factor 8, von Willebrand, and factor 13. Purified or recombinant von Willebrand factor concentrate, which contain only von Willebrand factor, no factor 8, may become available in the near future. When the patient undergoes dental extraction and sometimes nose bleeding, we can use both desmopressin and antifibrinolytic agent like aminocaproic acid or tranexamic acid. The last slide will be about Henoch-Schönlein purpura. It is a vasculitis disease characterized by sudden development of purpuric rash, which is present in 100% of the cases, 3/3. Arthritis and abdominal pain is present in 2/3 of the cases, while renal involvement is present in 1/3 of the cases. The characteristic rash in Henoch-Schönlein purpura consisting of petechiae, and these purpura are usually palpable and mainly present in extensor surface of lower extremities and buttocks. The coagulation studies are usually normal in this disease, and the pathologic lesions are present in the skin, causing development of this palpable purpura in the intestine, causing infarction of the bowel with melena, also in the synovium, leading to inflammatory damage of endothelia, causing arthritis or arthralgia. This inflammatory damage of capillary mediated by both white blood cell and macrophage, causing vasculitis. The trigger for Henoch-Schönlein purpura is unknown but may be related to viral infection. The therapy is usually supported by giving analgesic for joint pain or swelling, but sometimes in severe cases we might give the patient a steroid when they have melena with the abdominal pain or other severe symptoms. With this slide, I will end the lectures of pediatric hematology. The last slide shows you a picture for a child with Henoch-Schönlein purpura. Usually the rash is present on the buttocks and the extensor surface of the legs. Thank you very much.